Um, hopefully, we won't have any interruptions. I was just precepting, and I'm was waiting to see if one more person would come by, but I think Hannah was going to grab them and just make sure they knew that we were getting started with this. So I'm Kathryn Bell. I'm one of the assistant professors here with Marshall Family Medicine. I also work with our third-year medical students as the director for their clerkship, and I'm in charge of the director for one of our rural residency sites. I've got a clinical guideline to go over here today, red cell transfusion and acute myocardial infarction. I would not consider myself to be an expert in this. So if there are any questions that I cannot answer, perhaps there are other folks who would be able to answer this more readily. We do take care of patients. We do take care of patients on our hospital service with acute MI, but mostly non-ST elevated acute MI because all of our intervention is done at St. Mary's, and we're here at Cabell Huntington Hospital. So typically, if a patient comes in with an acute ST elevation MI, they will get transferred over to St. Mary's. And a lot of times, even in an in-stemming, if they have a significant history of coronary artery disease and it's likely that they will need intervention, it's not uncommon, even in that situation, for them to get transferred quite quickly over to St. Mary's. But we do have our patients with in-STEMIs that we keep on the floor with their medical management and heparin drips for so many 48 hours or so. So it could certainly apply to a good many of our patients down the road. My clinical case in this presentation is actually one that I kind of just drew up from several patients. The last 2 times I've been on the hospital service, we have had an in-STEMI patient each time, but both times their anemia was not such that it would apply in the situation. And then the last time I was on, we had a patient with some pretty significant coronary artery disease and peripheral artery disease that came in with a new onset cardiomyopathy and anemia, but was not actively having or had an MI in the hospital during that hospitalization. So based on these recommendations, I just kind of went down made up a patient that is kind of not all the way in the red or the black when it comes to being in a specific category in regards to restrictive versus liberal transfusion strategy. So all that being said, I recently just had to look up what the AABB stands for. That's the Association for the Advancement of Blood and Biotherapies. And they are the ones that are making this recommendation to lean towards more of a liberal transfusion strategy in patients who come in with acute myocardial infarction. I'm muted? Not here. Okay. Can you hear me?
Yeah, I can.
Good. She was saying, make sure I knew I was muted. I was like, everybody seems to really be putting on a good show for. So they are making this recommendation, and it does seem to be in line with the recommendation from ACC and AHA as well. And of course, that is in regards to again, it's a conditional recommendation. It's not an across the board recommendation. So let me get over here to my PowerPoint. So as you know, the restrictive red blood cell transfusion strategy with the hemoglobin cutoff of 7, less than 7, is what we usually call like our standard of care for most patients that we have in the hospital. That being a little different for certain populations regarding like patients who are already known to have cardiovascular disease, orthopedic surgery, or cardiovascular surgery are going to have a different transfusion cutoff. But in general, for most of our patients, we kind of tend to transfuse at or below 7 to reduce the risk of any kind of like transfusion reactions or other interactions, or again. Also, just because blood is not a resource that just is available all the time. It's not indefinite, so we don't want to transfuse without thought for given patient preference, possible complications, and also there is a finite amount of blood a lot of times that we have available, and we don't want to be careless with that. Acute coronary syndrome being a different situation, because we know that in both type 1 and type 2 MIs, The problem is there is a oxygen supply demand mismatch. So, blood being the way that we're going to get oxygen to our myocardial tissue, that maybe this is a different situation to consider, since that could, help treat the underlying problem. These newer randomized controlled trials, Reality and Mint, suggest possible harm with restrictive thresholds. So possible harm with restrictive thresholds in acute myocardial infarction. So this is why they are making that recommendation to follow a more liberal transfusion therapy in these situations. I focused mainly on the Mint trial because reading through this article, the Reality trial, I don't think, it was a smaller trial. I don't think it made as good of an argument for a liberal transfusion therapy. The Mint trial was still not a large trial, but I think that it did have more, reading through that one, I think there really was maybe more of an argument for a liberal transfusion therapy, especially in type 1 MI. So this is my case. We've got a 76-year-old woman who's coming in with a non-ST elevation MI. So I don't have on here whether she has a history of coronary artery disease to be known or not. And also that's not really important because again, she's coming in with a hemoglobin of 9.2 and over an hour it goes down to 8.1. So even if we knew that she had a history of coronary artery disease or cardiovascular disease, given the transfusion recommendations we've been following, we still would not plan on transfusing her with an in the situation of acute MI because her hemoglobin is still greater than 1. Thank goodness, greater than 8. So, given the guidelines that we've been following, let's say she has known coronary artery disease, her hemoglobin is still greater than 8. So normally I would not consider, transfusing her immediately in this situation, whether she has known coronary artery disease or not. So she's on the telemetry unit. She's had a drop in her hemoglobin from 9.2 to 8.1. There's no signs of bleeding. There's nothing to say that this drop has been from any kind of blood loss. And she's hemodynamically stable. She's got her blood pressure is 128/76 and her heart rate is 82. And we've got her already on your standard ACS guideline directed therapy. So the question is, given that her hemoglobin is now 8.1 and she's stable, but currently having an MI or non-ST elevated MI, do we want to transfuse her? Do we want to transfuse her to above 9? Do we want to transfuse her to above 10? Or are we happy with her being at 8.1 because that is the guideline that we have been following up until, I guess this was, I want to say June or May, or until now, really, because until now I had not read this article or seen this recommendation. Do we want to observe and transfuse if her hemoglobin were to drop below 8? Are we wanting to check this again in the near future and see, do we drop below 8? Or do we want to individualize that approach a little more? So here we are with these are the 2023 guidelines, which is the standard restrictive therapy, which we'd already discussed. For hemodynamically stable patients, a restrictive threshold of transfusing at less than 7 is what we would recommend. And then here under specific clinical scenarios, you see, if you're undergoing cardiac surgery, transfuse to keep above 7.5, or if you're about to have an orthopedic surgery, or we know that you have pre-existing cardiovascular disease, we would transfuse to keep you at or above 8. And the rationale behind that is because, again, we blood is not this thing that is a finite resource, and transfusions themselves come with their own risks for transfusion reactions, CHF exacerbations, different risks that we don't want to expose patients to if it's not really going to change their outcome. Again, myocardial ischemia being a supply-demand mismatch. So you've got, your oxygen supply is going to be reduced by the patient's anemia, and your O2 demand is increased by, in the setting of in the setting of a type 2 MI, more of just a a demand MI versus a type 1 MI where your demand mismatch is being caused by actual coronary artery disease, stenosis. We can't meet this supply because we can't get more blood to flow through these arteries that we can't dilate because of their plaques and stenosis. So risk worsening ischemia, anemia limits the heart's ability to recover. So jumping to the reality trial was 2021 JAMA, and it found non-inferiority in 30-day MACE, but the confidence interval was pretty wide. So from what I can tell, I mean, it's mentioned obviously in this article. I think really this MIT trial is what they're using probably more to make this recommendation. So the MIT trial randomized 3,504 patients with acute MI and anemia to either a restrictive or a liberal transfusion strategy. And these were both type 1 and type 2 MIs. And they did separate, the type of MI that they were having. I should have probably included the actual table in the PowerPoint, not. So if you look at, which page are we on? I think it is these are not numbers, so let's go with one. It's like the third page probably. You can see the tables that have the different patient. And then the page after that has like yeah, I think it would be this third page probably if you have the article that has the different outcomes and population sizes and type 1 versus type 2. So 3,500 patients, acute MI and anemia, restricted versus liberal, and they did separate type 1 versus type 2 MI. So their primary outcome was death or MI after 30 days. And what they found was that the outcome was similar for both groups, type 1 and type 2. Not both groups, meaning like the different transfusion strategies, but that the type 1 and type 2 outcomes at 30 days were pretty similar. In regards to the type 1 MI group, the primary events occurred in 18.2% of the patients in the restrictive transfusion arm and 13.8% in the liberal transfusion arm, which gave you a relative risk of 1.32, and the confidence interval is good. I think it did not cross 1, so a good confidence interval. But then when you move to type 2 MIs, similar event rates, but no real difference between the transfusion strategies. So now that presents a bit of a problem, because is it just that the type 1 MIs are going to benefit more? Is there really a difference? I think when they compared those two, they had kind of an inconclusive p-value of, 0.16. So again, this is why it's kind of like consider the patient and the situation and the risk for complications, because this does look like type 1 MI patients are at more risk for down, at 30 days for another MI or death if they are treated with a restrictive transfusion strategy as opposed to liberal. But then when you in type 2 MI, it doesn't really show that. And then when you kind of compare the two, it's kind of inconclusive. Or at least that's what I got from it. If somebody else read this and got something different, please let me know. But I think that's why they got to the implication here that the lower threshold, the restrictive transfusion therapy strategy, may increase risk in patients with especially type 1 MI. And again, you've got the AABB, the ACC, AHA, and CHEST. This is their 2025 recommendation that we're getting from this guideline update. Liberal strategy when hemoglobin is less than 10 in a hospitalized patient with an acute MI. So conditional, again, this is a conditional recommendation with low certainty. In the ACC and AHA recommendation 2025 class 2B, it may be reasonable to transfuse to maintain at or above 10. And again, you've got your ACS patients with anemia and no active bleeding. And then this one I didn't read so much. I did include it because they actually recommend against the restrictive strategy in acute coronary syndrome. So again, they're recommending against the restrictive strategy. They're saying it's reasonable to transfuse to maintain at or above 10. And then here it's saying we're going to suggest the liberal strategy. So really, both this recommendation and this one are suggesting against restrictive and for liberal. And here it's saying it's reasonable. Just think about the patient and their risk and how much it might benefit them. And again, none of these really differentiate between type 1 and type 2, but reading studies, it would suggest that type 1 patients tend to benefit more from a liberal transfusion strategy than a type 2 myocardial infarction might. So this is kind of like a little algorithm here. So obviously you're going to start, at the start with number one, where we always start, is the patient hemodynamically stable? Is there active bleeding? Is the patient hypotensive? So if the patient is hemodynamically stable, then go ahead and move on to 2 and start thinking about, what is my transfusion goal for this patient? If the patient's not hemodynamically stable, then do that first. Always start with your ABC. So you've got a hemodynamically stable, like the patient that we were just talking about in the case. She did have this 1-point drop in her hemoglobin since coming in, but that she's not got any active bleeding. She's got her heart rate and her blood pressure are both within normal limits. So now you've got this decision regarding hemoglobin. Obviously, if the patient's hemoglobin is less than 7, you're going to transfuse them. That's just kind of across the board for any patient. Now you've got the patient that's between 7 and 8, which is what we're calling kind of a gray zone. I think based on previous guidelines and this recommendation, I would say anything less than 8, I would go transfuse because the patient. This patient, again, I didn't put on there whether or not she did have known cardiovascular disease, but I mean, she is in for an NSTEMI right now. And I would say based on previous recommendations and this more current push towards a liberal transfusion strategy, I would say transfuse to keep at or above 8. I put strongly consider, based on like the black and white of what I'm reading in the guidelines. But in my personal opinion, I would say at this point, I would want to transfuse someone who's having an MI to keep them at or above 8 at least. And then here, 8 to 10 is reasonable to consider transfusing to keep them at or above 10. And, ischemic symptoms, are they continuing to have ongoing chest pain? What are you seeing? Again, we don't keep many ST elevation MI patients in our hospital. But outside of that, when you are at a hospital that treats ST elevation MI, it's like, what does their EKG look like? What does their telemetry look like? Or what are they complaining of? So here I would strongly consider to almost say yes. Here, again, reasonable, especially based on this new recommendation. And then this also is something to consider. You don't have to take a patient who has a hemoglobin of 8 and go ahead and just give them 2 units to try to get them up to, close to or at 10. You can take a patient who has a hemoglobin of 8 and you can transfuse 1 unit of packed red blood cells and then reevaluate. What are your vital signs? How are you feeling? Are you having chest pain? And then go ahead and recheck the hemoglobin, troponins, and EKG at that time. And then, if they've gone from 8 to 8.8 or 9.1 or something like that, you can kind of reassess at that time, do I want to transfuse to get them to 10 or greater? Or am I now happy based on the patient, their risk factors, and their current symptoms to leave them, at this threshold of 9? And of course, that's so. So back to our patient, we've got our 76-year-old female with NSTEMI, current hemoglobin of 8.1. She's not having any active bleeding. She's hemodynamically stable. Her hemoglobin, when it was first checked on coming into the ER, was 9.2. So, go ahead and ask yourself, is there any ongoing or recurrent, are you still having any chest pain? Are we seeing anything to suggest ongoing ischemia on your EKG, like ST depression? Is your troponin, we've got the 3 checks and it was rising, but now we've got our 4th to kind of watch your troponin and it's plateaued out and starting to come down. If that is the situation, then, you might feel comfortable leaving her at 8.1. Your next check on hemoglobin might be 8.5 anyway, since she came in at 9.2. So, if she's saying, I haven't had any chest pain since I came into the ER, her troponin has plateaued and is coming down, she has no EKG changes, it would be reasonable, I think, to consider, in just with that information, leaving her at 8.1 and checking her hemoglobin again in whatever you feel comfortable with. I mean, that's going to be, for me, it would probably be around 3 to 4 hours, given the drop when she first came in. Physiologic demand, is there tachycardia? Does she have a wide pulse pressure? Is there any new or worsening heart failure signs? Because I do believe, and I didn't write this down, but I also do believe through that MIT trial and reading in here that something that kind of stood out to me that I thought was kind of contradictory, because I wouldn't have assumed this, is that the actually patients with CHF, like acute MI and CHF, did better with the liberal transfusion strategy than the restrictive transfusion strategy, which in my mind, I would have immediately just thought, knee-jerk reaction, they have CHF, so let's be really careful about transfusing them. And of course, you do want to make sure that you are using diuretics and not fluid overloading a patient. But I think there was actually more benefit seen in patients with acute MI and a history of CHF when you were comparing them with patients who did not have a history of CHF. So let's say I decide to stay at 8.1 with this patient because all these things look fine. We check her hemoglobin again in 3 or 4 hours, and now it's 7.8. In that situation, I might decide to go ahead and transfuse a unit. Am I worried that that was secondary to bleeding? Maybe. We've gone from 9.2 to 8.1 to 7.8, not a big change. Maybe she's gotten some fluids. There might be other things to suggest to explain what's happening. But, definitely considering and ruling out any kind of occult bleeding. And then risk benefit, volume status, alloimmunization history, shared decision making. So treat the patient, not the number. If ischemic and high risk, transfuse. So you've got, and transfuse 1 unit at a time. So you've got a patient who we're here, and now we're going back to, she is having continued chest pain. Her troponins are continuing to rise. They have not plateaued. We're still seeing some changes on her EKG that might be consistent with ischemia. She's got a hemoglobin of 8.1. And right here, then go ahead and transfuse a unit, recheck the hemoglobin, reassess her, for any signs of ischemia. If asymptomatic and stable, again, like it said, it is reasonable to transfuse, but that also means close monitoring versus single unit transfusion is reasonable. It's reasonable to transfuse. It's reasonable to closely monitor and avoid just kind of like a reflexive transfusion. All right, so let's see here. Restrictive transfusion is still, again, we're talking about patients with acute MI. So restrictive transfusion is still standard of care for most hospitalized patients to reduce, unnecessary risk, and to be thoughtful in regard to resources. MIT and reality trials show signals of potential harm or increased cardiac death with strict restrictive thresholds, especially the MIT trial. And then you do want to take an individualized approach. Look at the patient. Instead of just saying every patient that comes in with a hemoglobin of 8.5 is having acute MI, should get a unit of packed red blood cells. Again, look at the patient. Do they seem to be, is their heart rate is normal, or they're tachycardic? They have EKG changes, or they don't. They're continuing to complain of chest pain, or they're not. So still take an individualized approach. But that there is but again, it is good to know there is this guideline shift, because AABB, the AAB, ACC, AHA, and CHEST are suggesting the liberal transfusion strategy, or advise against restrictive cutoffs, which I feel kind of like. And safe practice: transfuse 1 unit at a time, then reassess. And always, for our purposes, always document. Oh, where'd I go? Always document why you're deciding to give this patient another unit of blood, or why you're deciding not to give another unit of blood, and make sure that you talk to the patient about it. To make sure that they understand why you do or do not want to do this, so that they can make their own informed decision about it. And I think that's everything that I got.